Dr. Joe Kvedar, who is the founder and director of the Center of Connected Healthcare at Partners Healthcare. Joe?
Thanks very much. What a wonderful introduction to what I want to talk about, and I'm so pleased to hear your just very spot on the way you attack the law and what's at stake and what isn't. I run into this all the time where people think that everything we're talking about gets thrown out, and ensuring everyone is an important piece of it. But I would just echo that everything I'm going to talk about, the snowball is rolling down the hill. And it has to do with the fact that healthcare providers are being paid differently. And now in Massachusetts, this is not news. Partners Healthcare, where I work, which is the delivery system that is anchored by the Brigham and the Mass General, we are now at risk with essentially all of our payers in the state. Let me just review that because it means so much. We used to be paid by throughput through our institutions. We're now paid by efficiency with which we deliver care. It's a sea change. And it actually opens up opportunities for innovation like no other thing that's happened in my career in healthcare. And so it's in that context that I'd tell you a little bit about our center. We're 40 or 45 people, depending on how you count. We live within information systems at Partners, and we're dedicated to this concept that care should move out of the office, out of the hospital, and become a direct function in the lives of patients. This is really, I think, it's fair to say, the only service left on the planet that you have to visit someone to get the service. And it turns out, I've been at this now 17 years, but the reason I got involved was because I stumbled upon this idea that, gee, if you allow us to think about separating doctor and patient in time and place, you can unlock all kinds of value. And we've learned a lot of things along the way, but that was the sort of starting point, was this idea that we really limit ourselves by insisting that the only way you get our service is to come see someone like me in a physical location at a specific time. It's the only service left like that. So we're dedicated to figuring out what's appropriate, how to do that. We're not here to say face-to-face visits with your doctor are going to go away. On the other hand, you don't have to do everything that way, surely. Things like a blood pressure check. Why do you go into your doctor for a blood pressure check when we can measure your blood pressure all day long in your home if we want to? So it's that sort of thinking. We use technologies, predominantly monitoring and communications technologies, to achieve this vision. And we've had good success. I'll share with you a couple of programs as examples of what we've done, including improved engagement, which is really big, improved doctor and patient satisfaction, and improved quality and outcomes. So that's what we're about. Basically, we see two fundamental value propositions emerging in this work. And I want to share some examples that explain what these mean. So for improved self-care, and I would just digress for a minute to emphasize improved self-care, because I think that is the opportunity, in my opinion, for us to get out of this cost morass that we're in, is to give patients more to do. It's really quite simple. You check yourself in at the airport, you pump your own gas, you do your travel arrangements online over a website, you draw money out of a machine. Those are all jobs that used to be handled by people. In healthcare, you see 5 people on the way to see your doctor, and they'll ask you to fill out the same form that you just filled out. The 60% of our labor costs in healthcare, 60% of our costs are in labor. The remainder of the economy has gotten 1.8% more efficient with labor in the last 10 years. Healthcare is 0.8% less efficient. So that's an opportunity for anyone in the audience who's interested in entrepreneurial activities, is how can we make that labor force more efficient? We certainly can't attack the tsunami of chronic illness coming our way by hiring more doctors and nurses. We just can't do that and attack the cost problem at the same time. We have to think differently about this. So we started out thinking about this idea of just-in-time care. That's how we get started. Wow, if I had data coming from a patient in the home and I was a doctor or a nurse, I could probably make a more informed decision about their care. That was the idea. And we stumbled upon this idea that if you give patients that same information, they start to take care of themselves. And it's a beautiful thing. They manage their illness, they understand better, you can teach them in the moment because they have data in front of them. They use feedback loops to measure their success in the same way a batter uses a batting average to measure success, and it really starts to work. So it looks like this. I'm going to show you 3 quick examples. They all involve this idea of feeding patients their own information. That's what we call a feedback loop. I'm going to measure something about you and share it with you in context. Could be your activity level if you want to be more active. Could be your blood pressure if you have hypertension, your blood glucose if you have diabetes. It varies according to the condition. So we're going to measure that and then share it with you in context. We're also going to allow your provider to look at that in a population view. And that way, if I'm a nurse sitting in front of my population of diabetics and I see these 3 people are all having high sugars at 6 p.m., I can reach into their lives and say, let's talk about what's going on at 3 p.m. that's making your sugar bump at 6. And that prevents high-cost care from happening. It keeps people out of the high-cost part of the system. So example 1 is heart failure. The technology is shown at the bottom of the slide here. It's a weight scale, blood pressure cuff, and a touchscreen device. The people who are in this program are what I love to call the greatest generation. They're your octogenarians, people who are World War II vets, a lot of them. And one of the reasons the program works so well is because they wear a badge of honor that they're going to be compliant. So you give them a task. Weigh yourself every day, touch the screen, take your blood pressure. And by the way, if we don't hear from them by 10 o'clock in the morning, they get a phone call from a nurse. I noticed you didn't weigh yourself today. What's up? And very quickly, they're on the bandwagon. And then the other time they might get a phone call is if their weight goes up a couple of pounds. Heart failure is about managing fluid and salt, and the way you can quickly assess whether someone's got more fluid on board is their weight will change. So if my weight's up 2 pounds and I have heart failure, that could mean 2 more pounds and I'm in the emergency room. So they'll call up and say, gee, Mrs. Jones, I noticed your weight is up. Did you eat something salty yesterday? And these patients start to feel this sentinel effect. They're being watched. They feel cared for, so it isn't a bad kind of a sentinel effect. But they also, again, wear that badge of honor that that nurse is not going to call them. And the result is a 50% decrease in readmissions, all-cause and heart failure related. And speaking of payment reform, one of the first beachheads for payment reform is no more 30-day readmissions. Some of you may know this. So this is a tool that we can use to keep people healthy in their home, avoid getting them into the high-cost part of the system. And the happy news for us is that we're now all of a sudden incentivized to do it. So it's a nice story. The second one is blood pressure. So what's missing here is a little home hub. I apologize for that, but there's the cuff. We give these patients a little wireless hub. They can put it anywhere in their house. They can take their blood pressure anywhere in the house, and it just feeds over the cell network into our database where we display it for them in a similar manner that you see in this laptop here. And again, there's usually a nurse or a pharmacist in the practice managing a population of patients with high blood pressure who will look and maybe make a phone call once a week or see them in an office visit and say, let's go over your readings, how's your lifestyle change going, etc. Very powerful tool to lower blood pressure. And you can see 69% of these people achieved a lower blood pressure. And if you had high blood pressure or very high blood pressure, the worse off you were, the better your outcome. We had people who get a 25-point drop in their systolic pressure, which is a wonderful outcome. So again, it's this idea of feedback loops and then motivating people on top of it. And the final one, okay, so there's the little wireless doodad on the bottom of the slide. The final one is diabetes. Same concept. Swap out the glucometer, swap out the blood pressure cuff for a glucometer, and same concept. I'm uploading my blood sugar twice a day, which is, by the way, something my doctor asked me to do anyway. First time in history we've been able to really check that. How many times do you think we ask patients to test and they don't test? We all know diabetics that don't test. I'm sure you all know diabetics that don't test. Now we can say, gee, I notice you're not testing. Call them up. Call them out on it, and it makes a huge difference. So that's very powerful. And then again, seeing trends. In this population of patients, we've seen a 1.5 percentage point drop in A1C. It's directly correlated with how involved they are in their care. The more they upload, the better their outcome. Really interesting stuff. First time we've ever been able to look at it that way. The group has less hyperglycemic events, less hypoglycemic events, generally better control, and again, lower cost care over time. So that's an example of 3 programs. We do a lot more. We have a lot of other things going, but I want to be mindful of the clock and just give you a taste of the kind of work that we do. We also do consulting work. We do corporate-sponsored research, product evaluations. We have programs where we can help people who are anywhere from a guy with or a lady with a deck of slides to a Fortune 50 company. And we're very, very pleased to work in the commercial sector because so much innovation is happening there that we wouldn't ordinarily catch as healthcare providers. So our organization really is what I call a fence organization. We certainly do academic stuff. We publish peer-reviewed papers. We implement programs within partners, but we also are very, very involved in the innovation economy here in Boston and healthcare as well. And we do our symposium once a year, which I would urge you all to attend. It's in the fall. We have very attractive rates for students and people who work for nonprofits. It's a 2-day event. This year, October 25 and 26, we'll be at the Park Plaza, and it's 2 days of immersion in this growing marketplace of connected health. This is how to get a hold of me, and I know we're going to have a dialogue, so we'll take questions later, but I thank you very much for your time.
Thank you, Joe. Interesting stuff. I read an article today that just likened the change in the